All right, so let's move on to the final part of neurology, which is ophthalmology and audiovestibular disorders. Now, as a whole, this section on ophthalmology and audiovestibular disorders is not nearly as high yield as the other neuro sections, but it is fair game. It's worth going through. So let's go ahead and spend a little bit of time on these two sections. We're going to start on page 191 with normal eye function. So of course the retinal artery and vein are the vascularity or the vasculature for the retina. Vascular pathology affects vision, so occlusion of the retinal artery or retinal vein. Diabetic retinopathy is where you have specifically the proliferative diabetic retinopathy is where you have fragile new vessel growth, and those fragile vessels, also called neovascularization, those fragile new vessels can rupture, and in rupturing they can cause blindness because of vitreous hemorrhage. So we're just going through some more of this normal eye anatomy and functioning. The nerves innervating the eye, optic nerve, of course, for vision. Trochlear nerve is responsible for downward medial gaze and inward eye rotation. The abducens is your abducting muscle. Abducens nerve controls your lateral rectus, which is responsible for abduction of the eye. Your oculomotor nerve controls all of the other eye muscles. And also, the oculomotor nerve carries your parasympathetic fibers. And that's worth knowing because if you have a lesion to your oculomotor nerve, then that's when you get that blown pupil. And we talked about how an uncal herniation can cause that. The MLF contains your conjugate gaze, or maintains conjugate gaze when one eye abducts. We talked about how damage to your medial longitudinal fasciculus is commonly seen with multiple sclerosis. And if you see internuclear ophthalmoplegia, then that's damage to the MLF, and that's classic multiple sclerosis. Let's take a look at figure 8-7 on the next page. And figure 8-7 outlines the visual pathway, and you see here if you lesion a particular portion of the visual pathway, what that lesion corresponds to. So let's just go ahead. They don't name what these lesions are, so let's just go through these 1 through 6 on figure 8-7. So lesion number 1 there is lesion to the left optic nerve, and this is referred to as anopia. So you lose vision in one entire eye. Left optic nerve damage, anopia. Lesion number 2 is a lesion to the optic chiasm. That causes a bitemporal hemianopia. So lesion to the optic chiasm causes a bitemporal hemianopia, and of course the classic scenario where this takes place is a pituitary adenoma. Lesion number 3 is lesion to the optic tract, and that causes a homonymous hemianopia. So that's the term for that visual defect, is a homonymous hemianopia. Lesion number 4 is a lesion to the temporal lobe. A temporal lesion causes a upper quadrantic anopia. An upper quadrantic anopia, so an anopia just of the upper quadrant. Lesion number 5 is a parietal lobe lesion, causes a lower quadrantic anopia, so a anopia of the lower quadrant. And then lesion number 6 is a lesion to the visual cortex or the occipital lobe. And you see there, one thing you have with a lesion to the occipital lobe is sparing of the central part of your visual field. So this looks like lesion number 3, a homonymous hemianopia, but with macular sparing, with central visual field sparing. So that central sparing helps you to diagnose this as an occipital lobe lesion as opposed to the other ones which do not have that central sparing. While we're on page 129, let's look at table 8-16, common pupil and gaze abnormalities. This is a pretty important little table, not hugely high yield, but definitely fair game, definitely worth reviewing and knowing. So let's go through these. So your Argyll-Robertson pupil is a pupil that accommodates but does not react. And for that reason, it's sometimes referred to as the prostitute's pupil because it accommodates but it does not react. So it accommodates to near objects, but it's non-reactive to light. So you shine a light in this person's eye, and you do not see meiosis. But as you bring the finger close to the eye is going to become more miotic. That's Argyll-Robertson, classic for syphilis. All right, you see Argyll-Robertson, think about syphilis. the Marcus gun pupil. The Marcus gun pupil is referred to as an afferent nerve defect. An afferent nerve defect. So let's talk about your afferent nerve defects and your efferent nerve defects. These are your handouts. Page 16 of your neurology handout, number 1. Describe what light reflexes will be seen in both eyes if the right optic nerve is damaged prior to the pretectal nucleus, and this is the afferent defect. So what you have here is an absence of constriction of either the left or right eye when light is shown in the right eye. So you shine light in the right eye, and neither eye constricts. Neither eye is miotic. But both pupils constrict if light is shown in the left eye. So both pupils are able to constrict, but the right eye is not transmitting the visual signal very well. Number 2, describe what light reflexes will be seen in both eyes if the right oculomotor nerve is damaged. This is referred to as an efferent defect. So the signal getting to the eye to react is problematic, but the visual signal from the eye to the brain is not problematic. So what will happen here? The right eye will not respond to light shown in either the right or the left eye because the motor information is not being communicated. This is the efferent defect. The left eye will constrict when the light is shown in either eye. So the signal gets from the right eye to the brain, but it doesn't get back from the brain all the way to the right eye to cause the visual constriction. All right, other common pupil and gaze abnormalities on page 192. The table is Horner syndrome, ptosis, meiosis, and hydrosis. It mentions this is a sympathetic trunk lesion. This is an interruption of the cervical sympathetics. So if you interrupt the cervical sympathetics, fight or flight response is going to cause your pupil to dilate, so you're obtaining more visual information. So that's a sympathetic response. If you lesion your sympathetics, you do not have dilation. Instead, you have meiosis. So what causes this is a Pancoast tumor. Pancoast tumor is that tumor in the apex of your lung that interrupts your cervical sympathetics that causes Horner syndrome. We also saw that you can get a Horner syndrome as part of a cluster headache, or at least a partial Horner syndrome as part of a cluster headache. So be aware of that as well. Addy's pupil is a minimally reactive dilated pupil because of abnormal innervation of the iris. In the MLF syndrome, we talked about this in the last section. With lateral gaze, there's absent contralateral eye adduction, and there's also nystagmus in the abducting eye. So if I'm trying to look right, my abducting eye is going to have nystagmus, and my left eye is not going to be able to adduct. If I'm trying to look left, my left eye is going to have nystagmus, and my right eye will not be able to adduct. So this is classic for multiple sclerosis. This is MLF syndrome, or internuclear ophthalmoplegia is the other name for this. So definitely be aware of that. All right, let's move on to the next page, page 193, and talk about your common vision abnormalities. So page 193, table 8-17. Now, notice here that this is not hugely high yield. You don't see many bold terms here, but it is worth going through just to, it's fair game. So definitely be familiar with this, but don't spend a whole lot of time on this. So myopia, where the refracting power of the eye is too great, causing so the refracting power is too great. So myopia and hyperopia are because the eye is not refracting properly. So myopia, like it says in History of Physical, the vision quality worsens as objects move farther away. So this is where you have to look at something very close. You're nearsighted. Hyperopia is where the quality worsens as objects move closer, so you have to hold things far away. So somebody is reading a newspaper at a distance because that's the only way they can see it. That's a hyperopia, that's farsightedness. Astigmatism is an asymmetric corneal surface, so you have inconsistent refraction. So you have blurred vision. It's not a near-far issue, it's just simple blurry vision because your cornea is very asymmetric. So don't confuse the cornea, the surface of your eye, with the lens of the eye. Strabismus is deviation of the eye unable to be overcome by normal motor controls. This is where one eye is sort of wandering. This is like a wandering eye. The gaze for each eye is in different directions. Double vision, progressive blindness. So this is those people you don't know which eye to look at. That's strabismus. This is very important to diagnose this very early on. It's actually normal though to have a small amount of strabismus in the first 3 months of life. So intermittent strabismus in the first 3 months of life can be normal, but again, it has to be intermittent and has to be just limited to the first 3 months of life. Beyond that, it's not normal. How do we treat this? Vision training. Surgery is frequently required to achieve bilateral alignment. Now, this is very closely related to amblyopia. So amblyopia, they refer to it as lazy eye. Some people call strabismus lazy eye, all right? And because this is a euphemism, it doesn't, sometimes amblyopia is lazy eye, sometimes strabismus is lazy eye. So just know that lazy eye can refer to either one. Now, amblyopia is different. It's not just a wandering eye. Amblyopia is actually where one eye doesn't really function, because like it says there, it's a developmental defect in the neural pathways of the eye. So you have poor visual acuity and spatial differentiation just in the affected eye. Now, the most common cause of amblyopia, where you are not receiving, where the vision does not develop very well for one eye, the most common cause of that is strabismus. If your eye is wandering and not going where it's supposed to be going, then your brain is going to factor that out and just pay attention to the eye that is functioning properly. So let's take a look at your handout again, page 16, number 3. What is amblyopia and what are the signs and symptoms? Decreased vision due to a disruption in the normal development of vision, usually from strabismus, cataracts, or refractive error prior to age 10. So it doesn't have to be strabismus causing amblyopia. You can have one eye that has a cataracts of the lens or refractive error in the cornea or the lens, and that can cause the brain to factor out that signal from the eye and just pay attention to the other eye. Possible presentations of amblyopia, like your handout says, include esotropia, which is an inward deviation, exotropia, which is an outward deviation. So both of these are types of strabismus. Diplopia, which is double vision, and or refractive error not correctable with lenses. So how do we treat this? Back to page 193 for amblyopia. It says vision training, also levodopa, carbidopa. In general, you want to force the brain to recognize that eye that it is trying to factor out. So you patch the good eye for a certain period of time every day so that the brain is forced to recognize that eye that is not functioning as well. So that's how you treat amblyopia. Same thing for strabismus. You force the brain, you force the vision to the brain to use that eye that it doesn't want to use. All right, let's move on to eye inflammation and infection. Back to page 191 and talk about conjunctivitis first. So conjunctivitis, we're talking about red eye here. So conjunctivitis and eye infections and a red eye. So what's your differential for a red eye? So in general, there's 3 things that cause your eye to be red. 3 most common things that cause your eye to be red. There's viral infections, there's bacterial infections, and there's allergies. So a patient comes in of a red, itchy eye. Those are 3 things you want to have in the back of your mind. It's not always a bacterial infection. In fact, seldomly is it a bacterial infection. Usually it's either viral or allergic. But let's start by looking at these conjunctivitis facts, which is a quick hit on the margin of 191. So number 1 fact, adenovirus is the most common cause. So adenovirus is a viral cause of conjunctivitis. Adenovirus can also cause a diarrheal illness, and adenovirus can also cause URI symptoms. So any combination of those 3 things, you're going to want to think about adenovirus. If you have a diarrheal illness with a URI, think about adenovirus. Pink eye with URI or pink eye with diarrheal illness, think about adenovirus. Typically highly contagious and can be spread by contact with towels or linens or by close contact. Now again, we're talking about adenovirus here. Conjunctivitis can be caused by Neisseria gonorrhea and chlamydia trachomatis after sexual contact. So definitely be aware of that. If you have a conjunctivitis that's particularly purulent in a sexually active person, you're going to want to include that in your differential diagnosis. And conjunctivitis can occur in the perinatal period if the mother is infected with gonorrhea or chlamydia. Of course, that's going to cause a very goopy, very severely purulent conjunctivitis whenever you have a bacterial infection of the eye. So on page 191 at the bottom it says conjunctivitis is inflammation of the eye mucosa secondary to bacterial, Staph aureus, strep pneumonia, or viral infection or allergic reaction. So page 192. It's HMP, mildly painful eye, inflamed conjunctiva, possibly lymphadenopathy if there's an infection involved, Purulent eye when caused by allergy, purulent discharge when seen with bacterial infection. So a purulent eye discharge can be due to allergies, viruses, or bacteria. One of the distinguishing characteristics between bacteria and other things is the purulent discharge is very, very copious. It's a lot of pus that's coming out of the eye, and it's there all the time, 24 hours a day. If it's just a little bit of pus, or even a significant amount of pus that's just there in the morning, that's less likely to be bacterial. So let's talk about the distinguishing characteristics of each of these causes of conjunctivitis. This is on page 16, number 5. What are the distinguishing features of bacterial, viral, and allergic conjunctivitis? So bacterial, again, purulent, copious discharge 24 hours a day. Viral, like adenovirus, watery discharge is more common, but you can have a purulent discharge. The eyelid may be sealed in the morning from all the discharge. Other features, you might have a fever, URI, lymphadenopathy. You might also have pharyngitis. Allergic conjunctivitis tends to be bilateral, very watery, and the eyelid may also be sealed in the morning. Pruritus, that was a very distinguishing characteristic. Pruritus of the eye, pruritus somewhere else. Other allergy symptoms also can help you identify a allergic conjunctivitis. So what else here? Page 192 for the lab work, it says gram stain and culture of discharge may indicate a bacterial cause. Treatment, self-limited, topical sulfonamides or erythromycin reduce the duration of bacterial infection. So topical antibiotics for bacterial infections, which are less common than other viruses or allergies. Antihistamines may improve symptoms caused by allergic reaction. And fastidious hand washing decreases community spread of the infection. So for both the virus and for allergic conjunctivitis, antihistamines are what you're going to use. All right, so let's move on to uveitis on page 192. So uveitis, it starts by saying, what is uveitis? You can have an anterior uveitis, you can have a posterior uveitis. And a lot of times when we talk about uveitis, we're talking about an eye manifestation of a systemic disease, classically an autoimmune type or a rheumatic type of disease. But like it says in your book, it's inflammation of the iris. Inflammation of the iris would be an anterior uveitis. Inflammation of the choroids and ciliary bodies caused by infections like viral or syphilis. Autoimmune causes including ankylosing spondylitis, juvenile rheumatoid arthritis, inflammatory ulcerative colitis, Crohn's disease. You guys remember those HLA B27 systemic diseases that are your seronegative spondyloarthropathies. These are arthritic syndromes where the rheumatoid factor is negative. Most of those have a uveitis component to them at some point. And if you don't remember the mnemonic for those HLA B27 syndromes, PAIR was the mnemonic. P was for psoriatic arthritis. That's the arthritis with psoriasis, can have uveitis. A is for ankylosing spondylitis. I is for inflammatory bowel disease, which includes ulcerative colitis and Crohn's disease. And then R is for Reiter syndrome. So HMP, it says anterior uveitis, you have pain and photophobia. Slit lamp examination shows inflammation of the eye and keratin deposits in the cornea. Posterior uveitis, you have mild vision abnormalities. Slit lamp exam shows eye inflammation and retinal lesions. So how do we treat uveitis? Topical antibiotics if caused by infection, topical or systemic corticosteroids if not caused by infection, and basically you're treating the underlying condition, which would be one of those systemic rheumatologic conditions. All right, so let's talk about a few other things with reddening of the eye, uveitis, conjunctivitis. On page 16, number 6. Page 16, number 6. What causes of red eye most closely matches the following statements? All right, let's go ahead and go through these together. So the first bullet, may indicate a collagen vascular disorder. We just mentioned that one, is uveitis. So uveitis may indicate a collagen vascular disorder, one of those rheumatic diseases. There's also scleritis, inflammation of the sclera. So scleritis is very similar in that sense to uveitis. Potential serious complication of corneal ulceration is herpes simplex keratitis. Herpes simplex keratitis. This is where, classic scenario here is a zoster infection that involves the eye. You can get herpes simplex keratitis. Colored halos. If you have a red eye with colored halos, think about acute angle closure glaucoma. Acute angle closure glaucoma. An itching eye, again, think about allergic conjunctivitis. An itching red eye. A red eye with pre-auricular lymph node involvement. Think about viral conjunctivitis. A red eye with dry eyes. That's a keratoconjunctivitis sicca, S-I-C-C-A, keratoconjunctivitis sicca. And you get this with Sjogren's syndrome, right? You might remember Sjogren's as that syndrome where you have a deficiency of salivation. Well, you also have problems with lacrimation, so you get these dry eyes and red eyes. A shallow anterior chamber on slit lamp exam is also going to indicate acute angle closure glaucoma. Let's talk about a few more things with reddening of the eyes. Numbers and eye discharge along with it. So page 16, number 7. What is the most likely cause of conjunctivitis appearing in the first 24 hours of life? This is a chemical conjunctivitis resulting from the antibiotic eye drops that all newborns receive. So we give antibiotic eye drops or antibiotic eye ointment to all newborns just in case there was an undiagnosed chlamydia or gonorrhea so that the newborn is covered for that. And that can cause a short-lived chemical conjunctivitis, reddening of the eye in the first 24 hours. Number 8, what are the classic features that distinguish orbital cellulitis from periorbital cellulitis? So now we're talking about cellulitis, like cellulitis on the skin. You can also have cellulitis around the eye. Things that are characteristic of orbital cellulitis, which is much more severe than periorbital cellulitis. Periorbital cellulitis is just around the eye, the skin around the eye, but orbital cellulitis actually involves the eye. So you might have proptosis, bulging of the eye, proptosis with orbital cellulitis. Limitation of eye movements is very concerning here. This is ophthalmoplegia. Plegia, like hemiplegia, paralysis. Ophthalmoplegia is paralysis of eye movements or limitation of eye movements. So proptosis, limitation of eye movements, which is ophthalmoplegia. Decreased vision. If you have cellulitis around the eye, vision is normal, there's no proptosis, and the eye movements are not limited, that's much less concerning than if those things were there. And then a couple other things, if there's double vision or if there's pain with eye movement, then those are also concerning for orbital cellulitis. Number 9 on page 16, what is the treatment for orbital cellulitis? Not incredibly high yield, but since we're talking about orbital cellulitis, let's just go ahead and mention this. Immediate IV vancomycin plus IV cefotaxime or ceftriaxone until afebrile and clinically improved for 3 to 5 days, and then you switch to oral antibiotics for 2 to 3 weeks. So these are IV antibiotics. Patient needs to be in the hospital for a few days until this improves. Consult ophthalmology and ENT for recommendations and consideration of a need for surgical debridement. Just like with any cellulitis, you may potentially need surgical debridement. Before we go to the next page of your handouts, there's one that we skipped. So on page 16, look at number 4. What are the most common causes of blindness in the following population of adults in the U.S.? So we're going to talk about these in just a second, but let's go ahead and mention them here. So the first bullet, blindness, most commonly over age 55. The most common cause is macular degeneration. Macular degeneration. Most common cause of blindness under age 55 is diabetes, diabetes mellitus, and all the eye problems that can develop from that. And the most common cause of blindness in blacks of any age is glaucoma. And glaucoma is very high yield for your test. We're going to talk about it in just a second. All right, let's go ahead and go to the next page of your handout, page 17, and look at question number 10. What are the distinctions between a chalazion, hordulium, and anterior blepharitis, and what is the treatment for each? Chalazion, you have inflammation of the internal meibomian sebaceous glands. So you have eyelid swelling, usually self-limited. How do we treat it? usually self-limited, treated with surgical excision and or intralesional steroid injection. So it's just inflammation of those sebaceous glands. A hordeolium, also referred to as a stye, is an infection of the external sebaceous glands. These are tender, red, swelling at the lid margins. These are not within the eyelid, they're at the lid margin. How to treat these? Hot compress a few times a day. You might need to incise and drain these. An antibiotic ointment may also be helpful, but in general, the hordeolium can be treated with conservative therapy initially. Anterior blepharitis is an actual infection of the eyelids and lashes secondary to seborrhea. So you have red, swollen lid margins and dandruff on the lashes, consistent with seborrhea. Wash the lid margins daily with shampoo is how you treat this to get rid of the seborrhea. Remove scales with a cotton ball. Antibiotic ointment daily to the lid margins is helpful here. So subtle distinctions between these three, but I think it's worth knowing what makes a chalazion, a hordeolium, and anterior blepharitis clinically different as far as presentations. That's definitely fair game. Okay, so let's move on to cataracts. Definitely high yield. So on page 193, what is cataract? Is clouding of the lens of the eye. Don't confuse the lens with the cornea. This is clouding of the lens leading to progressive vision loss. Risk factors include trauma, particularly caustic substances. Diabetes is a huge risk factor for cataracts. Steroid use, another huge risk factor for cataracts, is long-term steroids. Being age, of course, being older, you're more likely to have this. Low education, alcohol use, tobacco use, and then one to add in there is sunlight. Long-term sunlight exposure increases the likelihood of you having a cataracts. History and physical, it's a progressive, hazy, and blurred vision occurring over months to years. Examination reveals opacity of the lenses and decrease of the red reflex. So this is a problem with the lens. So how do we treat it? We replace the lens. All right, you put a new synthetic lens in. Take the old cloudy one out. So take a look at page 17 of your handout. Look at question number 11. What is the classic presentation of a patient that has a cataract? Definitely high yield to be able to recognize this. Painless, progressive decrease in vision manifested with difficulty driving at night, reading road signs, and reading fine print. It's usually bilateral, but can be unilateral. Nearsightedness is often an early manifestation, and possible disabling glare in bright sunlight or from oncoming headlights, more likely with steroid-induced cataracts. So definitely be able to recognize that classic presentation of cataracts. Let's move on to glaucoma. Definitely hugely high yield for your test for step 2. So what is it? It's increased intraocular pressure leading to vision loss. We're on page 193 here. There's two different flavors of glaucoma. There's the open angle glaucoma and the closed angle glaucoma. So they're two different phenomena. Like it says there in the margin, that first quick hit, an open angle glaucoma is the most common type of glaucoma. And the next step says that any patient who requires frequent changes in lens prescriptions should be suspected of having glaucoma, and pressure testing should be performed. All right, so more things on open angle glaucoma, like it says letter A there. Gradual bilateral gradual bilateral increase in intraocular pressure. Risk factors are very similar to the risk factors that we saw with cataracts. Age, diabetes, but now being black is a risk factor for glaucoma. Of course, increased intraocular pressure, and the family history of glaucoma is also a risk factor. H&P, initially asymptomatic, gradual loss of visual fields, and this is important, from the periphery to the central. So you lose your peripheral vision first, and then that comes inward. This is different than a bitemporal hemianopia because your peripheral vision for each eye is the outside of your visual field. So if my peripheral vision for my left eye is right here, and my peripheral vision for my right eye is out here on both sides. So have the patient cover their eye to determine exactly where their peripheral vision is, both medially and laterally. Halos seen around lights can be seen with open angle glaucoma. Headache, poor adaptation to changes in the light. And this is also huge. Cupping of the optic disc seen on fundoscopic exam, specifically the cup to disc ratio is greater than 50%. So greater than 50% of that. If the cup is greater than 50% of the size of the optic disc itself, then that's diagnostic of open angle glaucoma. Lab, you can use intraocular pressure testing, which is tonometry, shows increased pressure over several tests performed at 2 to 4 week intervals. So that can be helpful, but ultimately to definitively diagnose this, that cupping of the optic disc is huge. So how do we treat this? There's lots of different topical agents that can be used for open-angle glaucoma. There's your topical beta blockers like timolol, your alpha-adrenergic agonists, your prostaglandin analogs. This is prostaglandin F2 alpha like lantaprost. All those prostaglandin drugs end in prost for prostaglandin. Your cholinergic agonists like pilocarpine. And there's another category which are your carbonic anhydrase inhibitors. So, but in general, those are the topical ones that you can use. And just be aware that topical agents for the eye can have systemic side effects. So topical beta blockers can cause bradycardia, so be aware of those things. Prevention is important, like it says there, for all at-risk patients who should receive regular ophthalmologic examinations, because you want to diagnose this before it goes undiagnosed too long, because as you start losing your vision, that's permanent vision loss that we're talking about here. Closed-angle glaucoma. It's also due to increased intraocular pressure, but in this case, the acute closed-angle glaucoma is due to narrowing of the anterior chamber angle and obstructed drainage of aqueous humor from the eye. Like it says here, that quick hit closed-angle glaucoma is usually unilateral. Risk factors include age, being Asian, hyperopia, dilated pupils, low light environments, and optometry examination dilation. So what do we have going on here? How does this present differently than the open-angle glaucoma? Under H&P, you have eye pain. So you didn't have any pain with a subacute open angle. Acute angle closure, you have eye pain. You have blurry vision. Halos definitely seen around the lights. Nausea, vomiting because it's so painful. Eye is inflamed, it's hard, it's dilated, and it's non-reactive. Right? So you can see an eye with acute angle closure glaucoma in this image up here. It's a very red eye, and it's a fixed, dilated pupil. So it's not reactive to light. You shine a light in this patient's eye, and it stays like this. It stays exactly the same. It's fixed, it's mid-dilated, it's red. So lab work, the tonometry will be able to demonstrate an increased intraocular pressure, but the slit lamp exam is going to be particularly helpful here as well. How do we treat this? So acetazolamide is the carbonic anhydrase inhibitor that we were talking about. Decreases pressure. Pilocarpine can be used. One very important thing is that next step in the margin where it says never induce additional pupil dilation during examination of patients with suspected closed-angle glaucoma because it will acutely worsen the condition. So very, very important to know that. All right, let's take a look at page 17 of your handout, number 12, and talk about the treatment for acute angle closure glaucoma. So how do we treat acute angle closure glaucoma? You can use a pressure-lowering eye drop regimen. So several different drops can be used. You can use your beta blocker, timolol, adding with iodopine and pilocarpine. So that's a combination. You can also give acetazolamide, oral acetazolamide. So acetazolamide is not drops, it's oral tablets. So that's one option, trying a bunch of different eye drops with oral acetazolamide. Again, you're trying to get this taken care of as quickly as possible because this is an acute phenomenon. If refractory to the above combination, you're going to use mannitol. Mannitol is given IV once the diagnosis is confirmed by an ophthalmologist. And surgical intervention includes laser peripheral iridotomy, where a tiny hole is made in the periphery of the iris so that aqueous humor can flow into the anterior chamber. So that's what last resort for angle closure glaucoma is make it so that the aqueous humor can flow. All right, let's talk about some of your retinal disorders on page 194. The first one is macular degeneration, definitely high yield for your exam for step 2. So macular degeneration is there's two different types here. There's the atrophic or slow degeneration, and there's the exudative degeneration of the macula. So what it is degeneration of the retina, leading to retinal fibrosis and permanent vision loss. What causes this? Or what is it exactly? let me just say that quick hit in the margin. Let's take a look at that. It says macular degeneration is the most common cause of bilateral vision loss in the elderly. So definitely important to know that. Risk factors: being white, using tobacco, family history, increased age, prolonged sunlight. So we saw sunlight was a risk factor for cataracts, as is age. We see sunlight and age are risk factors for macular degeneration also. Hypertension is a risk factor. HMP, this is painless. This is not painful like acute glaucoma. Gradual loss of vision, central to peripheral this time. So with the open-angle glaucoma, we had peripheral to central. With macular degeneration, the vision loss is central, and then it goes outwards. Retinal pigmentation is the atrophic type, and hemorrhage is the exudative type. Radiology, you can use this fluorescein angiography, may show neovascular membranes in the retina. Very important to know the treatment here. So the treatment is vitamin supplementation, specifically vitamin C, vitamin E, copper, zinc, and beta-carotene. So add beta-carotene to that list. And you might go to the pharmacy and you can see, over-the-counter eye vitamins. Well, those over-the-counter eye vitamins are specifically designed to help treat and prevent the development of macular degeneration, especially in elderly patients. It also mentions for the exudative lesions, you can use this intravitreal ranibizumab. So it's in the vitreous that you give this, in the vitrium that you inject this. What this ranibizumab is a vascular endothelial growth factor. So it's a vascular endothelial growth factor. It helps the exudative lesions. And laser photocoagulation can also be very helpful here. Complications: treatment effectiveness is limited, gradual progression to severe vision loss. Moving on, the next retinal disorder is retinal detachment. Okay, it's very easy to identify this on your question stem. You need to know how this presents, and that's number 3 there, HMP. It's painless, acute loss of vision. So with open angle glaucoma with macular degeneration, those were gradual vision loss. Retinal detachment, it's acute vision loss, all right? So it's like a window shade pulled over the eye, numerous floaters. Sometimes you'll see, sparks, you'll see flashes of light, and then you won't see much of anything anymore because your retina is being detached. Pigmented fragments or a gray retina floating in the vitreous humor seen on fundoscopic exam, of course, it's going to be easy to identify that. So what causes this? Risk factors: trauma, of course, that's what would cause your retina to detach like that. Cataract surgery, myopia, and family history. How do we treat it? Laser photocoagulation or cryotherapy to halt tear progression and reattachment of the retina, which still may not fully restore the loss of vision. But the main thing here is being able to identify the classic presentation of retinal detachment. Retinal vessel occlusion. So we're talking about retinal artery occlusion and retinal vein occlusion. Like it says here, number 2, both of these are most commonly caused by atherosclerosis, diabetes, hypertension, and thromboembolic disease. HMP, the retinal artery occlusion, you have a sudden painless loss of vision. Fundoscopic examination shows cherry red spot on the fovea and poor arterial filling. So this is like a stroke of your retinal artery, okay? So this is, again, painless. It's sudden. Retinal vein occlusion is more gradual. It's painless also, loss of vision, and you have cotton wool spots, edema, and retinal hemorrhage in addition to dilated veins. So let's look at these color figures that it refers you to. Color figures 8-2, 8-3, and 8-4. Let's start with color figure 8-2. So color figure 8-2 is on color plate 4. You have diabetic retinopathy. You have lipid exudates, so these are your cotton wool spots and the small retinal hemorrhages as well. So that's classic for diabetic retinopathy. You can see cotton wool spots in lots of different disorders. In diabetic eye disease, in hypertension, in HIV eye disease, you're going to get cotton wool spots, among other different disorders. So cotton wool spots are very nonspecific. So this is more of a non-proliferative diabetic retinopathy. You can also, I mentioned earlier, have a proliferative diabetic retinopathy where you have neovascularization, small, fragile, new blood vessel growth, and those new fragile blood vessels tend to rupture and cause vitreous hemorrhage. So take a look at color figure 8-3. You see here retinal artery occlusion, that cherry red spot. So what can cause a cherry red spot that looks like that? You have retinal artery occlusion can cause this. Niemann-Pick disease, and also Tay-Sachs disease. All three can cause those. And the last color figure we're going to look at here on color plate 5 is color figure 8-4. We have retinal vein occlusion, and here you see the edematous retina, retinal hemorrhages, cotton wool spots, and the venous dilation. So you can see that around the macula, the venous dilation, classic of retinal vein occlusion. Again, more subacute, more gradual loss of vision as opposed to the retinal artery occlusion, which is a very sudden loss of vision. All right, let's go back to page 194 and talk about the treatment. So treatment for retinal artery occlusion, thrombolysis should be performed within 8 hours of the onset. Acetazolamide and oxygen to decrease congestion and increase perfusion for artery occlusion. And the laser photocoagulation can be used for venous occlusion. Complications without prompt treatment, permanent vision loss can result here. All right, so be able to recognize those and know classically how those appear on a fundoscopic exam. Let's talk about a few other eye pathologies. Page 17, number 13. Treatment for corneal abrasion. Now, fair game for your test to know this, not incredibly high yield, but I want you to see what the treatment for corneal abrasion is because it's just so common, and it's just something you need to be aware of before you move on to the next step in your training. So, corneal abrasion treatment, thorough eye exam, topical antibiotics 4 times a day until the eye is symptom-free because you don't want it to get infected, over-the-counter lubricants as needed up to hourly. Pressure patching for less than 24 hours is optional, but generally not necessary. So if you have a corneal that has an abrasion, in general, we do not pressure patch it. There's no role for pirate patching, so there's no role to put a general patch over the eye. Pain control, very, very important. It can be painful, so make sure you address the pain. Never prescribe a topical anesthetic here or topical steroids. And then 24-hour follow-up for contact lens abrasion, a large abrasion, or an abrasion with diminished vision. So those are things to be aware of. Number 14, what disease would you suspect in a 35-year-old female with new onset rapid loss of vision and pain when moving the eye, and how would you treat this? So this is 35-year-old female. She's in that 20 to 40 range. She's female, vision loss, eye pain. This is optic neuritis that we talked about with multiple sclerosis. And this is a very common initial sign with multiple sclerosis. This is optic neuritis. So the treatment here consists of IV steroids, and I told you it's going to be 500 to 1,000 milligrams a day over several days. So you might give methylprednisolone 125, give 2 doses 4 times a day would be an example of what you could do there. And number 15, what eye abnormalities might be seen in a patient with vitamin A deficiency? You can have night blindness or complete blindness, xerophthalmia, which is dryness of the eye. You can have Bateau's spots, areas of abnormal squamous cell proliferation and keratinization of the conjunctiva, so be able to recognize that. All right, so let's move on to your audiovestibular disorders now on page 194, starting with otitis media. So we're talking about acute otitis media here, of course. This is an infection of your middle ear. That strep pneumo is the most common organism. Also is Haemophilus influenza. Now, we're not talking about the type B Haemophilus influenza that tends to cause meningitis or very severe meningitis. We're talking about the non-typable Haemophilus influenza here that's commonly implicated for acute otitis media. There's also Moraxilla catarrhalis and strep pyogenes, and viruses can cause acute otitis media as well. Number 2 in your book mentions increased risk in children due to shorter and more horizontal ear canal than adults. Pacifier use increases your risk. Hypertrophic tonsillar tissue can increase your risk of acute otitis media. So chronically enlarged tonsils. History and physical, ear pain, decreased hearing, fever, bulging of the tympanic membrane with decreased motility. So that is in bold terms here. So make sure you know those organisms that are bolded, and also that you diagnose this with a bulging tympanic membrane with decreased motility. So that's more sensitive than just a red tympanic membrane. So red tympanic membranes may or may not indicate otitis media, but if the tympanic membrane is not mobile and it's bulging, then that's more likely to be acute otitis media. And that's how you make your diagnosis. Poor light reflex may or may not be helpful. Possible bloody discharge with perforation. So, the classic scenario where you have a perforation is you have a patient that has a lot of ear pain, and then all of a sudden the ear pain goes away, and there's a bloody or exudative discharge associated with that relief of pain. So be able to recognize that as a perforated acute otitis media. So how do we treat this? It says initially observation and supportive care. Let's talk about that a little bit. Look at page 18 of your handout, question number 1. When is observation without antibiotics appropriate for a child with acute otitis media? According to these guidelines from 2004, you're supposed to refrain from using antibiotics and simply observe if the child is 6 months to 2 years and the diagnosis is questionable. Maybe you just have a redness of the tympanic membrane with or without motility. If the illness is not severe, if appropriate follow-up is available, and antibiotics can be started promptly if symptoms worsen. So all of those criteria have to be met. If it's a severe illness, if the kid's younger than 6 months of age, if they are not going to have good follow-up, or if you can't start antibiotics promptly, then you should go ahead and treat. If the child is older than 2 years of age and the illness is not severe and appropriate follow-up is available and antibiotics can be started promptly if symptoms worsen, that is another scenario where you can go without antibiotics. So note here that you've taken out the illness is not severe. So you can have a pretty severe illness in a kid older than 2, and as long as those other criteria are met, you can go ahead and try a watch and wait. But it also says antibiotics should be started if improvement is not noted in 48 to 72 hours. So if the child is not getting better in 2 or 3 days, then you should go ahead and start antibiotics regardless of everything else, regardless of all those reasons that maybe you didn't start the antibiotics. So at the bottom of page 194, it mentions for unresolved cases, amoxicillin for 10 days. It's worth mentioning that this is high-dose amoxicillin. This is not just, medium or low-dose amoxicillin. It has to be high-dose amoxicillin for 10 days. Resistant strains may require other medications. It mentions trimethoprim sulfamethoxazole. Usually, if it's a strain resistant to amoxicillin, the next step is amoxicillin with clavulanic acid, which is brand name is Augmentin. So amoxicillin with clavulanic acid is the next step, and you can also use stronger cephalosporins. On the next page, 195, recurrent cases may require surgical placement of tympanic tubes to assist in middle ear drainage. Complications. This is definitely important to know what the complications are. Mastoiditis. We're going to talk about that in just a second. You can have local extension of the disease causing a meningitis. You can have hearing loss. You can have sigmoid sinus thrombosis or even brain abscess in untreated cases. Now, of course, this is not very common to have these very severe problems, but they can happen. Ruptured TM is another one you might add in there, a ruptured tympanic membrane. You can also have a labyrinthitis, which we're going to talk about in just a second, and bullous meningitis as well. So let's talk about some of these things. So let's see, number 2. What are the classic signs and symptoms of bullous meningitis? So bullous meningitis is a bullous vesicular inflammation of the tympanic membrane that may occur in association with acute otitis media. It typically manifests with being more painful than a usual acute otitis media. And on an otoscopy, you see large reddish vesicles on the TM, large reddish vesicles on the tympanic membrane. What is the treatment? Number 3, mycoplasma. So mycoplasma pneumonia is a common organism. So you treat this with oral macrolides like erythromycin or clarithromycin. So mycoplasma is a common organism treated with oral macrolides like erythromycin or clarithromycin, and then topical analgesics as well are important. It's a very painful ear. Address the pain. Always address the pain. Number 4. What are the diagnostic features of mastoiditis? So we said that mastoiditis can be a complication of acute otitis media as well. So here the symptoms occurred days to weeks after developing acute otitis media. You have erythema and edema, tenderness behind the ear where your mastoid process is. The external ear might be displaced, and the diagnosis is made with a CT scan of the mastoid process. CT scan of the mastoid process. So you make the diagnosis of mastoiditis with a CT scan of the mastoid process. All right, so let's move to otitis externa, so outside otitis or swimmer's ear on page 195. So this is an infection of the outer ear, of course, most commonly caused by Staph aureus or Pseudomonas or even Staph epidermidis, frequently associated with water, just like Pseudomonas is loves moist environments, tennis shoes, contact lenses, burn victims' wounds. Pseudomonas loves wet ears. H&P, painful swollen ear with possible white discharge. The ear canal is red and swollen. Tenderness of the pinna, so if you tug on the ear a little bit, that's very painful to the patient. When you insert your otoscope into the ear, that's very painful to the patient. And the tympanic membrane is going to look normal, so that means it's not acute otitis media. So how do we treat otitis externa? Topical antibiotics, so topical polymyxin or neomycin with or without hydrocortisone. So you may or may not want to give a steroid for this. I'm not so much a fan of giving steroids unless you absolutely have to, but some physicians have a very low threshold for giving steroids. That's sort of a physician preference nowadays. Oral cephalosporins or ciprofloxacin can be used for Pseudomonas or infection that spreads to involve the skull. That would be more of a mastoiditis that we just discussed. Topical drying agents after water exposure to prevent the recurrent infection. So if you have somebody that has a history of otitis externa that likes to swim in lakes or rivers, you want to make sure you're going to dry out the ear with something like vinegar, possibly to reestablish the acidity, the normal acidity of the ear environment, and help get rid of the infection. Moving on, let's talk about your vertiginous disorders. So vertigo, lots of different things can cause vertigo. We mentioned that schwannoma can cause vertigo, an acoustic schwannoma. There's also a benign paroxysmal positional vertigo, BPPV. So let's talk about that on page 195. So BPPV is vertigo where you have abnormal feeling of rotational movement leading to poor balance with coordination caused by a dislodged otolith in the inner ear that interferes with the semicircular canal stabilization. So history and physical, you have episodic vertigo that's very brief, can occur with certain head movements like looking up, rolling around in bed. So if you have vertigo that's worse whenever you're in bed and you roll to one side, that's very commonly BPPV. Nystagmus, the Dix-Hallpike maneuver is one of the ways that you can diagnose this. So moving from the sitting to the supine while quickly turning the head to the side. So you have the patient sit up, have them lay down, and then you turn their head to the side. If that induces vertigo, induces nystagmus, then that's it's going to confirm your diagnosis. So that's your diagnostic test, is a Dix-Hallpike maneuver. Lab work, you might check a TSH, but in general you may or may not have to do that. Radiology. If this goes on for a long period of time, you might need to get a neuroimaging, CT or MRI of the brain. Again, you might need to rule out a schwannoma. Treatments, physical maneuvers designed to free the otolith from the semicircular canal and alleviate recurrent episodes. So this is due to a dislodged otolith. The little stones in your inner ear are not in the right place, so you use maneuvers to realign those otoliths into the right place. The most commonly used maneuver is what's called the Epley maneuver, E-P-L-E-Y, the Epley maneuver. I'm not going to go into what you do for the Epley maneuver. It's pretty easy to find that on the internet, but that's one of the maneuvers you can use to treat benign paroxysmal positional vertigo. All right, another vertiginous disease that they don't have in your book that is worth knowing is acute labyrinthitis. So acute labyrinthitis is on page 18 of your handout, number 6. So the distinguishing characteristics to be able to diagnose this, it's an acute onset of vertigo, nausea, vomiting, nystagmus, so that's very nonspecific. If the auditory function is preserved, we call that a vestibular neuritis. If there's hearing loss associated with that, we call that a labyrinthitis. It's a single episode, lasts days to weeks, but usually not longer than 2 weeks. It's typically preceded by a viral URI, maybe preceded by acute otitis media as well. Nystagmus is horizontal, suppressed with visual fixation, has a fast phase away from the affected side. There's an abnormal head thrust test when the examiner rapidly turns the patient head to the affected side. The patient is unable to maintain visual fixation. There's gait instability but preserved ambulation and absence of focal neurologic defects. So that's acute labyrinthitis, worth being able to recognize that. So what is the treatment for acute labyrinthitis? This is on page 19, number 7. So the treatment for acute labyrinthitis typically subsides spontaneously within weeks. A corticosteroid taper can improve recovery, so you might consider a steroid taper. Symptomatic treatment only for the first 48 hours of the illness includes a scopolamine patch, meclizine, which you might know better as Antivert, metoclopramide, which you might know better as Reglan, and then promethazine, which is an anti-nausea drug. But again, if you're going to use something to decrease vertigo and nausea, only for 48 hours. Because like it says there under the next hash mark, long-term recovery is theoretically delayed if used long-term. So definitely important to know that. Vestibular rehab exercise, very important. If the patient is over age 65, if there's a headache associated with vestibular labyrinthitis, if there's focal neurologic signs, if there's vascular risk factors or sustained vertigo, then get an MRI because it could be a schwannoma or something more serious. So that's just a general rule for vertigo. If you have any of those other things with vertigo, that's when you get imaging, you get the MRI to make sure nothing else is going on. The next one on page 195, definitely important to know, is Meniere's disease. So Meniere's disease is endolymphatic hydrops. So this is a vertigo caused by distension of the endolymphatic compartment of the inner ear. So you have acute vertigo again. It's a vertiginous disorder. It lasts several hours, nausea, vomiting, decreased hearing, feeling of ear fullness, and tinnitus. So vertigo with ringing in the ears, tinnitus, and decreased hearing. Those three things, you're going to think about either Meniere's disease or think about schwannoma also. The acute labyrinthitis does not have the tinnitus component, whereas Meniere's and schwannoma has vertigo, decreased hearing, and tinnitus. Lab work, the audiometry is going to show a low frequency hearing loss. The thing with Meniere's disease, it's a chronic disorder. So it's a disorder that goes on for a long period of time, even though the exacerbations may last several hours. So it's a very disabling disease, unfortunately. And there's a lot of depression associated with people that have Meniere's disease because it's so disabling. And a lot of some patients might actually commit suicide because the ringing in their ears and their vertigo and decreased hearing is just so prevents them from functioning so much at all. How do we treat Meniere's? Anticholinergics can be helpful, antiemetics, antihistamines. Salt restriction, and it says acetazolamide. This is a typo. It should be thiazides. So salt restriction and thiazides may reduce the frequency of the episodes. Surgical decompression needed in refractory cases. So how do we surgically correct a Meniere's disease? We're talking about obliterating the vestibular apparatus of your ear. We can use gentamicin in the ear, so injecting gentamicin will obliterate that. The labyrinthectomy, taking out the labyrinth, and you can also do a vestibular neurectomy. So those are three procedures. Infusion of gentamicin, labyrinthectomy, and vestibular neurectomy are all procedures to surgically correct or obliterate the problem with Meniere's disease. Let's talk about the acoustic neuroma or the acoustic schwannoma. Again, another vertiginous disorder, the bottom page 195. We said it was the third most common primary brain tumor in adults. It's a tumor of Schwann cells leading to hearing loss. Due to nerve compression, you have hearing loss, dizziness, tinnitus. So we mentioned very similar to Meniere's disease. You can also have facial palsy, but you may or may not have that. Audiometry is going to show sensory neural hearing loss. The MRI is going to allow you to make the diagnosis, and you have to surgically excise these to treat this. So he said that audiometry is going to show sensory neural hearing loss for acoustic schwannoma. Let's talk about the differences between conductive hearing loss and sensory neural hearing loss. And that's what you see on that quick hit in the margin on page 195. So conductive hearing loss says that pathology occurs along the conductive pathway from the outer ear to the inner ear. So the most common cause of conductive hearing loss is otosclerosis. Otosclerosis, it's fixed sclerotic otic bones. So your malleus, incus, and stapes get sclerosed together. They don't function. So that's otosclerosis, causing a conductive hearing loss. And of course, having your ear canal fill with wax can cause a conductive hearing loss as well. But for otosclerosis, that's going to require hearing aid or surgery. And like it says, their audiometry is going to show preserved air conduction, but consistently low hearing threshold. And it mentions the RINA test. So let's talk about the RINA test and what exactly that is. So the RINA test is a test that you perform with a vibrating tuning fork. All right. So initially, what you do is you tap the tuning fork, get it vibrating, put it on the patient's mastoid process behind the ear until the sound is no longer heard by the patient. And then you put the fork just outside of the ear. So it starts on the mastoid. When they don't hear it anymore, this is bone conduction on the mastoid process, and then you put it outside the ear. All right. In a normal ear, the air conduction, when you put the fork outside the ear, is going to be better than bone conduction, which means after you move it from the mastoid to over the ear, they will be able to hear it over the ear, whereas they didn't hear it at the mastoid. So that's a positive RINA test. That's normal. Air conduction is better than bone conduction. With a conductive hearing loss, that is not the case. So you have a negative RINA test, where you hear the fork on your mastoid process, you stop hearing it, you put it over your ear, and then you still don't hear it because the conduction is poor. All right? So with a conductive hearing loss, wax, otosclerosis, you're not going to hear that air conduction as well. With a sensory neural hearing loss, first of all, you have hearing loss, you've diagnosed that there's hearing loss, and with a sensory neural hearing loss, it's going to look more positive. You're going to have a positive RINA test where air conduction is better than bone conduction. So with a hearing loss where air conduction is better than bone, that's sensory neural, and a hearing loss where bone conduction is better than air conduction, that is a conductive hearing loss. So sensory neural, again, could be due to acoustic neuroma or schwannoma. On the bottom of page 195, what else does it say about sensory neural hearing loss? It's pathology in the neural pathways from the ear to the brain, which is why it's sensory neural. Audiometry shows both impaired bone and air conduction, asymmetric Weber test, and a positive RINA test. So a positive RINA test. This is normal, but in the face of hearing loss, you know that that is a sensory neural hearing loss. All right, and one last pathology I want to mention regarding the ear is a cholesteatoma. Definitely important to know for your test. And the cholesteatoma is addressed on page 18 of your handout number 5. So what is cholesteatoma? It's, like it says in your handout, overgrowth of desquamated keratin debris within the middle ear space that may eventually erode the ossicular chain and external auditory canal. So what type of hearing loss would you have here? This would be a conductive hearing loss, right? Causes, negative middle ear pressure, a chronic retraction pocket from eustachian tube dysfunction, or direct growth of the epithelium through a TM perforation. So those are two scenarios that can cause a cholesteatoma. Commonly associated with chronic middle ear infection. On physical exam, you have a grayish-white pearly lesion behind or involving the tympanic membrane, a conductive hearing loss, vertigo. Treatment, surgical removal, usually involving tympanomastoidectomy and reconstruction of the ossicular chain. This is something, once it's there, it's not going to go away, and it's only going to get worse. So if you see this, if you see that pearly lesion at or behind the tympanic membrane, it has to be surgically corrective because it's just going to get worse. It can get terribly worse. All right, a few other things I want to mention here. On page 19 of your handout. Number 8. What is the most common cause of conductive hearing loss in adults, and what's the most common cause of sensory neural hearing loss in adults? So the most common cause of conductive, we mentioned this earlier, is otosclerosis. Again, that's where the otic bones become fixed. And the most common cause of sensory neural hearing loss is presbycusis. Presbycusis. Number 9, what is the treatment for Ramsay-Hunt syndrome? So Ramsay-Hunt syndrome is herpes zoster oticus. So herpes zoster that involves the ear, and you use narcotic analgesics for pain relief because this can be so painful, oral steroids to decrease inflammation, and antiviral therapy with valacyclovir has the highest efficacy, but you can also use famciclovir or you can use acyclovir. Acyclovir being the one that's been around for the longest. It's the lowest cost, but it's 5 times a day dosing. All right, so that's it for the eye and the ear. So go ahead and take a look at your Neuro Part 4 quiz. It's on page 20 of your Neuro handouts. Go ahead and answer those questions, and then we'll go through those answers together. All right, so let's go ahead and go through the answers to this Neuro Part 4 quiz. Number 1, 10-year-old boy develops worsening arm and leg weakness over a period of 3 days that has now worsened to include symmetric facial muscle weakness, deep tendon reflexes are absent, and sensation is intact. What's the diagnosis? This is classic for Guillain-Barré syndrome. All right, so Guillain-Barré is not just a problem with adults. Kids can get Guillain-Barré as well. Number 2, what's the differential diagnosis for dislocation of the lens of the eye? We didn't really talk about this. Probably more important for step 1, but I wanted to mention it here for step 2. Marfan syndrome, this is where the lens typically dislocates upwards. Homocystinuria, this is where the lens typically dislocates downward. And then Alport syndrome, can't see, can't pee, can't hear, is Alport syndrome. So Marfan's, homocystinuria, and Alport's can cause dislocation of the lens of the eye. You can also have a traumatic dislocation of the lens of the eye as well. Number 3, explain how the Weber test can help distinguish conductive hearing loss from sensory neural hearing loss. The Weber test is where you place a tuning fork on the forehead. All right, so we didn't explicitly describe this, but you place a tuning fork on the forehead. If it's heard best in the affected ear, that's a conductive hearing loss. If it's heard best in the unaffected ear, that is a sensory neural hearing loss. Number 4, how is benign paroxysmal positional vertigo diagnosed? It's with the Dix-Hallpike maneuver. How is it treated? Is with the Epley maneuver. Number 5, with which disorders might you see a cherry red spot on the macula, Tay-Sachs, Niemann-Pick, and central retinal artery occlusion? Number 6, what is the treatment for macular degeneration? In general, vitamin supplementation is particularly important for macular degeneration. We said that beta-carotene, vitamin C, vitamin E, copper, and zinc. And this is for the atrophic macular degeneration. If it's the exudative macular degeneration, you're going to give the intravitreal ranizumab or laser photocoagulation. The ranizumab was that vascular endothelial growth factor. What is the treatment for retinal detachment? You need to stop the progression of the detachment with either cryotherapy or laser photocoagulation. And you need to reattach the retina, which may or may not spare the vision. But it will help recover some of the vision, usually. Number 7, what are the risk factors for the development of cataracts? They include trauma, especially caustic substances, diabetes, corticosteroid use, being older, so age is a risk factor, low education, alcohol use, tobacco use, and sunlight exposure are all risk factors. Number 8, what are the classic features that distinguish orbital cellulitis from periorbital cellulitis? So we mentioned that proptosis, limitation of eye movement, which is the ophthalmoplegia, and decreased vision, also pain with eye movement, and double vision. Those are all things that are more likely to be orbital cellulitis instead of periorbital cellulitis. What is the treatment for acute angle closure glaucoma? You're going to start with the combination of the eye drops, which can be a combination of beta blockers, alpha adrenergic agonists, cholinergic agonists, and prostaglandin analogs. So a 3-drop combination of those. You can also give acetazolamide orally, and if that combination of acetazolamide plus several eye drops does not work, then you're going to give mannitol IV after the diagnosis has been confirmed. And if that's not working, ultimately you can use a laser peripheral iridotomy, where you laser a hole into the iris so that the aqueous humor or the vitreous humor can communicate anteriorly. Number 10, what's the next step in the management of a patient that has sustained a chemical burn injury to the eye? It's copious water irrigation. And the longer you wait before you irrigate, the worse it becomes. So you have to irrigate as rapidly as possible. If you have a patient that comes in with a burn injury to the eye and they said that they've irrigated their eye at their work location, you still need to irrigate again when you get them to the ER to make sure it was done adequately and properly. Number 11, what's the easiest way to distinguish a hordoleum from a chalazion? A hordoleum is in the lid margin, and a chalazion is actually within the eyelid itself. And number 12, what eye abnormality is seen when there's a suspicion, when there is a lesion to the oculomotor nerve, the eye is fixed and dilated, it's that blown pupil because of interruption of the parasympathetic innervation, so you're left with just sympathetics, and the eye looks down and out. So down and out, fixed dilated pupil. All right, so that is it for neuro.